Hi, Dr. Westbrooks. This is Tyler Parker. I'm in your Family Therapy with Children's class, and I'm going to do a presentation now on ADHD, attention deficit, and hyperactivity disorder. Okay, so to start off with, how do we know it when we see it? So, what are some of the things that a parent, a teacher, other people will notice about someone that'll bring them to, maybe start to question whether someone has ADHD? So first and foremost, usually they're easily distractible, but first I should probably say that there's the inattentive subtype or the type, and then the hyperactive subtype. So they're easily distractible, meaning that staying on task is something that's kind of difficult. There's a low tolerance of frustration, meaning if given a task, the person will not usually fight through the hard parts to get to the end of whatever it is that they have to do, but they usually want to give up because they have that low tolerance for frustration much sooner than most other people would. Low tolerance for boredom. This can be seen in the classroom a lot because if a teacher's lessons are not necessarily very engaging, the first ones to disengage are probably going to be the kids who have ADHD. Impulsiveness, the inability to sort of manage one's own behavior and make sure that what someone is doing is appropriate for the context in which they're in. So that's a pretty big one, and that's one that you would probably see in a multitude of different contexts, maybe not necessarily just in the school, but also at home or at church or wherever else the context-dependent behavior would be. Forgetfulness, I mean, lots of people can be forgetful, but when it's found in the symptom constellation with the rest of the symptomatology present with ADHD, then it would be considered kind of an issue. And restlessness, that could kind of go with low tolerance for boredom too. It might look just the same if someone's squirming around during class and they don't really want to pay attention. So the criteria that's used for ADHD diagnosis all comes from the DSM-5. This presentation is not about the particulars of every single one of those diagnostic criteria, so I won't go into too much of that here. But just to, make mention of the previous slide, some of those things are, going to be found. And of course, there's going to be specifics, and a person has to meet a certain number of clinical criteria to be considered, having a clinical level of ADHD or whatever. So one of the most important things that you have to do is assess for comorbid and comorbid conditions and conduct a differential diagnosis. So some of the big things that we're looking for: ODD, CD, conduct disorder, specific learning disabilities, and mood disorders. So all of those things need to be, determined not to be the symptoms that one is seeing. So, I'll go into some of the differential diagnosis criteria. So for example, oppositional defiant disorder, you want to differentiate if the person or the child or whoever is just being negative or hostile and is defiant. And that's the reason why they're unable to perform whatever functions are being requested. Because if they are defiant and it's not that they are just, inattentive, then that's two completely different problems. Intermittent explosive disorder, there's serious aggression towards others. So maybe the hyperactivity is not just, gross motor movement all over the place, but it's actually aggressive behavior directed towards someone. That might instead be intermittent explosive disorder. Neurodevelopmental disorders, so if there's high motor activity and it's not stereotypical or stereotypic or repetitive, then it might be ADHD. But if it's repetitive behaviors, like maybe arm flapping or something like that, then you would be looking more towards a neurodevelopmental disorder. But if it's just general high activity hyper behavior, then it's probably not neurodevelopmental disorder. It's probably more in line with the hyperactivity and ADHD. Specific learning disorders. So you want to look for the context in which the specific learning disorders manifest. Typically they're academic contexts, and when a person is removed from those academic contexts, then you don't see the same set of problems. So that's how you'd be able to differentiate whether what you're seeing is a specific learning disorder rather than just simply inattentiveness. Intellectual disability. So non-academic contexts typically don't see manifestations of intellectual disability. So that's one way that you can tell, because the clinical criteria for ADHD specifies that you have to see the behavior in more than two contexts. So if you only see it in one context, then you might be looking at, an intellectual disability rather than ADHD. Autism spectrum disorder, or ASD. So the social functioning aspect of ADHD that kind of gets in the way sometimes has to be differentiated from self-isolation from peers rather than rejection. So for example, kids with ADHD might not want to take turns. They might talk over people. They might borrow things without asking first. And their peers might not want to hang out with them very often because they conduct themselves like that. Well, that's a completely different instance than someone who prefers not to socialize with anyone, and maybe hasn't had some of those run-ins where people have an opportunity to say, we don't want to hang out with you, but it's more of the self-isolation. So even though, at the end of the day, both kids might be eating lunch by themselves, it all depends on why they're eating lunch by themselves. Reactive attachment disorder. So the social disinhibition doesn't come with the symptom cluster of ADHD. So although a person might have, they might not be able to control themselves in social places and in social connections and contacts, they don't have the other symptom clusters of ADHD. So that's how you differentiate that. Anxiety disorders. So the inattention given a task is not because a person is not able to focus. Rather, it's due to maybe worrying or rumination or something like that. So it's not that they're getting distracted with external stimuli or even maybe their own thoughts, but they're not performing the task because they're worried about something. So it's important to sort of be able to figure out, okay, this kid or this person is not performing this task. Well, why is that? Are they distracted or are they worried about something? So that's really important. Depressive disorders, so concentration issues are not due to depressive episodes. You want to make sure that you're, very accurately determining whether a person is sad and that's why they're not doing well, or if it's because they're inattentive and that's part of their ADHD symptom cluster. Bipolar disorder is episodic in nature rather than prevalent like ADHD is. So if you see maybe ADHD type symptoms, that might be sort of the high side of the bipolar disorder, but it goes away, then you might be dealing with bipolar disorder rather than ADHD, because ADHD doesn't just go away on its own like that, and it's not episodic in nature, it's prevalent in several contexts. So disruptive mood dysregulation disorder. If a person is pervasively irritable and intolerant of frustration, and it's not task or context specific, then you might be looking at disruptive mood dysregulation disorder instead, because ADHD is more context and task specific. So if it's just all the time, then you might be dealing with something a little bit different. Substance use disorders and psychotic disorders are kind of self-explanatory, I guess. Like, you can do different things to see if a person is using drugs and that's what the problem is. If they have a psychotic disorder, there's going to be a multitude of different things that are going wrong, I guess, for them at the same time. So you don't really need to worry about that so much. Medication-induced symptoms of ADHD. So if a person's medication is kind of giving them a hard time and they're starting to exhibit symptoms as if they had ADHD, that's something that their primary care physician or prescribing physician would have to work out with them instead. Neurocognitive disorders, so those are, later onset, I guess you could say. And so, you might see some of the same symptoms of inattention, for example, but dementia looks very, very different than ADHD does, as far as I know. So, prevalence and correlates, 3 to 6% of the adolescent population is said to maybe have ADHD, so that's about one child in every classroom. Language, motor, and social development delays, I kind of touched on that a little bit, especially talking about, the friends or the people, at school that might push a person away. But also, language development is said to be one of the correlates of ADHD as well. Delays in language development. Impaired academic and work performance, that kind of goes without saying, because if a person isn't really paying attention or not getting it, or they can't sit down long enough to retain information, learn it, and use it later, then you're going to see impairments in the academic context and work performance as well. If you can't stay on task for something for very long, you might not finish very much and you might get fired. So, that could have a multitude of other cascading effects along with it as well. So increased risk of suicide attempts when there's comorbid mood, conduct, substance, and substance use disorders as well. Definitely when a person gets older, then that becomes a problem. If they've been dealing with the same set of issues for a very long time, it's very likely that the person is going to have an increased rate of suicide. Okay, so prevalence and correlates continue just like I talked about earlier. There's a specific set of symptoms that come along with ADHD, and those are just some of them. So demographic prevalence, I'll go through this very quickly. About 5% of children, 2.5% of adults are said to have ADHD. And ADHD doesn't just go away usually for adults. So children of parents with ADHD are at a higher risk of getting ADHD. It seems to sort of, I guess, be passed down from parents to children pretty often. So, obviously the children of a parent who has ADHD is going to be of a higher risk for that. It's predominantly males, 3-to-1 to 6-to-1 prevalence of males versus females. And the females don't typically have the hyperactivity type of ADHD. It's mostly just the inattentive type. So I don't know if that's maybe due to, social upbringing or social expectations, but they definitely do have different manifestations of ADHD. So African American and Latino children are thought to be underdiagnosed. That might be because the social expectations of African American kids and Latino kids might be a little bit different. Maybe squirming around and being active and, doing that sort of thing is normal. Or it could be, maybe the stigma attached to having ADHD or even having to go see somebody about a mental health disorder. So there's a number of different things that might get in the way of maybe, trying to figure out why there's an undiagnosed or underdiagnosed rate in those populations. So like I said, culturally appropriate practices relevant for assessing ADHD are very important, so that a clinician can see, okay, what's really going on here? Is this actually ADHD, or is this, outside the expectations of what's considered a norm for them? All those things really matter, but there is no known socioeconomic status correlate for the prevalence of ADHD. So like I talked about, hypothesized causes, parents having ADHD, so trait-specific predispositions, that's just the personality of the child, so behavioral inhibition difficulties and negative emotionality. If a kid is like that, then they're probably at a higher risk of actually having ADHD. That doesn't mean that they have it, that just means that, they're predisposed to having ADHD because of those character traits. Low birth weight and utero exposure to harmful substances. As usual, don't drink and smoke when you're pregnant, okay? Or get anywhere near lead or mercury. Abuse, neglect, and placement in foster care also seem to be hypothesized causes of ADHD, and of course those things go with a lot of other mental health disorders as well. So the duration of the disorder, it's chronic, but it may be context dependent. So if a person has ADHD, very likely they're going to have it for the remainder of their life. Long-term risk in adulthood associated with ADHD, like I said, increased rate of suicidality, suicide attempts, and things like that. Just generally not having a great time. Treatment side effects, so that goes for the psychopharmacological interventions, not necessarily for the psychotherapeutic interventions, and that's going to be dependent on the medication administered. So that's something that needs to be worked out with the primary care physician or the prescribing physician or psychiatrist. Societal views about ADHD, it's controllable with medication only. When Ritalin came out, it was this whole big thing, and people were all about just give my kid a pill and they're going to be okay. All right, so that's kind of still how I view it today. There's no distinctions made really between hyperactive and inattentive subtype. So whenever someone says ADD or ADHD, they're not really talking about which one is present in certain contexts. They're just kind of like lumping it all into the same category. It's just easier like that. Teachers usually recommend diagnosis without proper clinical oversight or testing. This is kind of a big one. If a teacher's class is not engaging for a kid, if a kid is expected to sit down for 60, 90 minutes a day in this class that they don't like and not move at all, they might be inattentive. They might be a little bit, fidgety and things like that. So I think that it's very important to make sure that we're not seeing that as a reflection of what's wrong with the child. That might be a reflection of, the classroom management of the teacher. That might be, the pedagogical strategies of the teacher and how well they're actually able to engage their students. If they give a kid an opportunity to stand up every once in a while in class, maybe they wouldn't be diagnosed with ADHD because they'd have an opportunity to get out some of that natural energy. But anyways, that's besides the point. Bored kids with lots of energy are likely to be referred for assessment because they're moving around a lot. The inattentive kids as well, but that's why it's important to have your differential diagnosis done very accurately, because it might be due to some other reason why the child is being inattentive, whether they're depressive or they're anxious about something else is very important to determine. So stereotypes and judgment, parents cannot control their kids. That's what you hear a lot of times in society, even though it might be due to the ADHD. A child with ADHD might be given a free pass for all sorts of behavior. So, if a kid's like, oh, I have an IEP, I have ADHD and I do da-da-da-da, that doesn't mean that you can just do whatever you want. That means that that's something to take into consideration. But that doesn't mean that a person or a teacher or anybody else should just turn a blind eye to that behavior. It means that they need to be, even more aware of what that child is doing, and making sure if they have a behavior plan with the parents as a parent management technique, or even with the child with self-initiated sort of behavior management techniques, that's a time where someone who's observing the child needs to intervene and say, hey, you're supposed to be doing this, or your strategy when you're feeling like that is to do blah, or do you need to go to the nurse and take a pill, right? So people can claim to have ADHD when they really don't. People say it all the time. People have been saying it for a really long time. If it's even a little bit hard to focus, or they're divergent thinkers, they sort of think that that's what ADHD is all about, but it's not. So approaching treatment with someone who doesn't want to medicate their child. So I would let them know that there's pros and cons of medication, and medication doesn't have to be a frontline treatment for ADHD. It's something to consider, especially if you need that extra edge, to make sure that you can actually reach the child with the behavior management techniques, sort of calm them down a little bit. Then that's something that can be considered, but it's not something that should just be taken off the table if it's going to end up helping the child. But of course, that's the parent's decision to make. And it should be advertised as basically a supplement to the treatment that they don't have to take if they don't want to. Now, if someone wants to just give their kid a pill and hope that it all works out, so some success may be found with that, but the unfortunate thing is that medication does not teach behavior management strategies. So if a person were to just take a pill, that doesn't mean that they're going to have the strategies that are necessary to lead a successful life with the brain that they were born with. You basically just kick the ball down the court, punt, if you will, if you take medication and you never actually deal with the underlying issues. Because, what if you skip a medication dose? What if you're on vacation and you don't have medication anymore? And you're trying to woo your fiance, to get her to marry you, but all of a sudden you don't have your medication anymore and she sees this whole different person. Of course, that's just a hypothetical, but the thing is, these are the tools in the brain that you have, and learning how to work with it the best that you can is probably going to be the best option. So I would not advocate for strictly just medication, because there's a lot of strategies that a person's going to miss out on. So like I said, later life problems may develop without that early intervention. So benefits of treatment with the marriage and family therapist, parent management strategies and child-initiated behavior management strategies equal empirically validated successful outcomes. Okay, so it's all about successful outcomes at the end of the day. If you do both those things, if the parents know what to do, the kids know what to do, you're probably going to have a good outcome, and an MFT can help with training for that. So some more benefits of treatment with a marriage and family therapist. So MFTs and school counselors plus medical practitioners plus parents plus child input equals accurate, relevant, and working IEPs. So because ADHD is typically diagnosed when a child is during school age, you want to make sure that their IEP, if they have one, is actually going to be relevant and accurate, and it actually works. And it's something that everybody's on board with, and they all can say, okay, this is the plan of action that we have. You know, maybe you have extra time for tests, maybe you're allowed to do this, maybe you're allowed to do that. But at the end of the day, it's all about the education and success of the child. So with the medical, behavioral, school, and family all coming together, that's going to equal success. So last thing, the medication-only approach, that's really not a problem-solving strategy at all. It's a band-aid strategy. So necessary lifestyle changes can occur because a person doesn't know how to actually work their own brain. They're not fully at the controls of their own mind and their own body. They're sort of letting the medication try and do that for them. So they're going to really have a hard time making those critical life decisions that are necessary to leading a happy and successful life. So multi-method approaches are validated to be the most effective for treatment. Surprise, that goes with just about everything. You know, you have to work the controls of your brain, and also, if you need to, have a little bit of help with medication. So problems that are not addressed and conquered early may get worse over time, or lead to a higher prevalence of, you know, suicide attempts and things like that, substance use disorders and things like that later on in life. Okay, so that's about it for that. I hope that was sufficient. I hope that I answered all the questions that I was supposed to. And this is my references. So I use the DSM, the OR article, and the READY article, or the chapter. Okay, so like I said, Dr. Westbrooks, it was good to sort of internet meet you. And if there's any questions, just let me know. Thanks.